is Adrian Lee. I'm a medical oncologist and a board director of the Brain Cancer Group. And on behalf of the board, I want to welcome you all to the Brain Cancer Group's 8th awareness raising event held annually here at New South Wales Parliament House. We acknowledge the traditional owners of the land on which we are meeting tonight. We pay our respects to the elders past, present and emerging, and the elders from other communities who may be here today. In particular, we want to thank our parliamentary hosts, the Member for Canterbury, the Honourable Sophie Cotsas, New South Wales Minister for Industrial Relations and Minister for Work, Health and Safety. Unfortunately, I don't think Sophie's joining us tonight, but we do thank her for her ongoing support and for inviting us to our inaugural event here at Parliament House in 2016 and for hosting all subsequent events. Sophie remains a firm friend and supporter of this Brain Cancer Group. In particular, we want to thank all the parliamentarians that are here present tonight, who will be joining us on what we recognise is a very busy sitting day. We also acknowledge Brain Tumour Alliance Australia, BTAA, represented here tonight by a number of their committee members. BTAA and the Brain Cancer Group have forged a strong partnership, bringing multiple education events to the brain cancer community. Also this September, TBCG will once again sponsor BTAA's Patient Forum, which will take place at the beginning of the Cogno Conference in Gold Coast. We look forward to teaming up with BTAA to bring more such events to the community. All will be filmed and available on our website. In particular, also now, but last but not least, we want to welcome all our distinguished guests here tonight, our ambassadors, patients, families, carers, donors, sponsors, supporters, business and community leaders, and representatives of other brain cancer organisations. Ordinarily, I would ask Sophie to come up and deliver some remarks, but obviously we will push on at the moment. So the schedule of play is as follows. I will open up with the introductory talk on gliomas and highlighting the challenges and potential barriers in delivering brain cancer care in regional centres. After this, there will be a video presentation of patients and colleagues in the brain cancer community from the regional areas to hear from their own voice, their concerns on this topic. And then we'll hear from Professor Michael Back, a fellow board director and radiation oncologist, who will deliver his thoughts and views on ways to tackle these challenges and barriers. And in closing, another board member, Dr. Jonathan Parkinson, neurosurgeon, will present closing remarks. So let me switch over to this. This is going to test my left-right orientation because of the way we've set up the PowerPoint, but so do forgive me. We'll have my slide. Yep. Okay. So obviously I know this audience knows glioma very well, but just in case there are some new faces in the audience, I'm going to try and do a very quick tour of what glioma is all about so that everyone is on the same page before we go further. Then we will take a deeper dive into the care delivery of brain cancer patients, and the differences and the challenges and the barriers that we face as we see it from the city compared to the country. Brain cancer is obviously a very, very scary term. Having cancer is already bad enough, let alone a cancer or tumour in the brain. It often will come with loss of function, loss of independence, and lots of worries about the future. Quite often in the clinic, we are not just focusing on the medicine side of brain tumours, but also the psychosocial elements for the patients and their carers. The stress in the clinic is often very palpable. The fear and anxiety of wanting to know everything there is to know about brain tumours, the fear of the unknown, the lack of control are feelings that we see on our side of the table in the clinic room. And I'm sure those of you who are familiar, the patients, the families, are going through these emotions a million times each and every day. Taking a step back, let's dissect this a little bit. When we talk about brain tumour in this forum, for tonight's purposes, we will focus on gliomas, the #1 primary brain cancer. Even that as a description is quite broad, as it encompasses a few different diagnoses with very different trajectories. Gliomas in general account for, like I said, it's the most common brain tumour. It's 94% of all primary brain cancer diagnoses. These are not secondaries, these are not meningiomas. They come from glial cells. Glial cells are important in the brain and spinal cord because they support the nervous system. They are the glue that holds everything together, allowing the nerve fibres to send electrical signals up and down, running smoothly and quickly. In this diagram on the left, we can see that within gliomas, the top box in the green, which is probably a little bit hard to see, that can be further split into 3 groups of diagnoses. Of note, and most commonly known, is GBM, or glioblastomas. We do have also RDH mutant astrocytomas, as well as 1p19q co-deleted oligodendrogliomas. As it is well known amongst this audience, GBMs carry a very poor prognosis. Median survival is around 15 months. Oligodendrogliomas and some of these astrocytomas, however, though, their prognosis can be measured in years, 5, 10, 15, and sometimes beyond that. Some will never have a problem again, and some will experience some worsening or evolution to more aggressive cancer types. Why is this important in our care delivery? We'll come back to this. When a patient is suspected of a brain tumour or GBM, they often will have headaches or loss of function. Inevitably, they will get many, many scans, such as these MRIs usually, or if not, CT scans. And obviously to us, the diagnosis stands out like anything. But technology has advanced, and so in addition to just identifying and diagnosing the problem, MRIs and PET scans have enabled our surgical colleagues to cut the tumours out more safely and also identify areas where the tumour might be heading to, which can be further mopped up by radiation. All of these strategies and improvements give us the best chance to improve cancer control and to enable our patients to live longer with less deficits. Traditionally, once the surgeon cuts it out, the sample gets sent to the lab, and our pathology colleague, and I know some of them are here tonight, don't heckle, please, gets sent to the lab and look at it under a microscope and make the diagnosis, nice and simple. Not. Nowadays, what is seen under the microscope is only a fraction of the final report. Some bits of the samples are now being sent to other parts of the state, other parts of the country to do fancy gene sequencing. Why is this important? This information gives us more knowledge, better knowledge, to work out how these gliomas may behave and the likely trajectory for each patient. And in the future, hopefully provide new targets for drugs. All of this information, they get presented each week in our MDT meetings, multidisciplinary team meetings, in front of a panel of specialists, neurosurgeons, radiation oncologists, medical oncologists, pathologists, radiologists, nurse practitioners. We all gather around each week, discussing each case, working out a management plan as a team. And it's not just the new patients that we discuss. We also review ongoing patients who, as the audience knows, gets a lot of scans. Over time, we know there are a lot of these changes on MRIs, especially after they've had surgery or radiation. Some of these look benign, some of these look sinister, and some of the sinister ones can turn out to be benign, and some of the benign ones can turn out to be sinister. But basically, you need the whole team and the collective experience to decide and to help guide the management decisions. And we also have access to PET scans and advanced molecular data that can help us determine the risk or the likelihood of something bad happening or vice versa. Unfortunately, of course, this can't be done in every single centre, in every single hospital. So this, again, very familiar to the audience here tonight, is a diagram of the Stoop protocol designed by Professor Roger Stoop in Switzerland in 2005. For better or for worse, this has stood the test of time and is still the standard approach to GBMs after 20 years. One can only hope if we were doing this talk in 5 to 10 years' time, we will have a different slide to put up. But for now, at the moment after surgery, everyone gets 6 weeks of chemoradiation therapy. There's a 4-week break, followed by 6 months of more chemotherapy. During this period, we are seeing the patients monthly, analysing their symptoms, looking at scans, adjusting their medications. Our goal is to delay worsening of the cancer, improving function and independence, and hopefully reducing the stress burden for the patient and for the carers. I'm going to turn to the other end of the glioma spectrum. We have these low-grade gliomas, where the cancer typically and unfortunately affect our younger population, although not exclusively. Different to GBMs, seizure is often an ongoing issue. Treatment is also quite different in that after surgery, depending on the biology of the cancer, depending on the type of resection or the extent of resection, some may go on to active surveillance, while others may need start on radiation followed by chemotherapy. And more recently, we've even had a new targeted drug for vorasidenib to be used in these patients with the hope to delay the need for radiation and chemotherapy. It is pending PBS approval. So, sorry, I've skipped a few things. So just taking a step back now, moving away from the science to the stats. We've highlighted that there may be a concern, but is that true? Is that borne out by the stats in New South Wales as well as in the country, around the country? So first of all, the age-adjusted incidence rate for new brain cancer diagnosis is 8 per 100,000 people population across Australia, which obviously is not a huge volume by any means. This table describes the number of new cases that have been recorded in Australia each year for the past 6 years. As you can see, there hasn't been much of a change, thankfully, in brain cancers. Pancreas, by percentage terms, probably changed the most. But yes, we are definitely outnumbered by lung cancer, breast cancer, kidney even, and prostate cancer. What is also different that is not portrayed in this table is the range of treatment that's available for all the other cancer types on the screen, except for pancreas again. All of these treatments are now backed up, supported, researched, and supported by PBS and Medicare, and they've been game changers. These are the immunotherapy, these are the targeted therapies. People with melanoma, which I've not highlighted, they are living longer with durable control of disease. And yet, ultimately, we are still using a 20-year-old recipe. In New South Wales, in 2021, we had 652 new cases of brain cancers diagnosed, roughly about a third of the total that was diagnosed in Australia that year. Now, this might cause some controversy, but this is the table, if it shows up well enough. The incidence recorded against local government areas across the state. Now, the top 10 are all regional centres for whatever strange reason. Noting the average is 8, so number 10 falls in at 9.8. And certainly at the bottom end of the table, we have a lot more city councils. The big question, of course, is why is there a difference? We don't know. Perhaps some of you might have some ideas or clues. Turning to mortality rates. So in New South Wales, the age standardised rate for mortality from brain cancer was 4.9. And as we can see, mortality rate was also substantially higher in our regional centres, except for Strathfield. Not sure what's happening in Strathfield either. They've made it into the top 10. And again, in the bottom 10, we see a lot more inner city or Sydney council areas. The diagram on the right splits this by the local health districts. And again, the pattern appears to be consistent in that the regional LHDs have poorer survival statistics compared to the city centres. We have another outlier, Southeastern Sydney Local Health District. Not sure what's happening in Randwick and St George, but hopefully they will improve over time, or maybe it was a bad couple of years for them. Ultimately, it's up to us as a brain cancer community to improve the outcomes for our patients, especially in the regional centres. To start with, we need to highlight and find out what the barriers are and the challenges that may be driving these high numbers, and work on ways to improve and counter these problems. So how do we compare with the rest of the world, or in countries like Canada, US, and the UK, or is this a unique issue that we see in Australia because we are a vast and big country? The international experience tells us a recent paper from Canada demonstrated similar findings, showing regional variability in survival. They looked at the differences in survival in the bigger provinces like Ontario, where Toronto sits, and British Columbia, where Vancouver is, compared to the smaller provinces and the smaller states, smaller territories in the Atlantic region, and there was a significant survival difference between the two. Other countries have looked at similar data, although in a parallel way. They were more comparing volumes, high volume versus low volume centres. This was done in US as well as in the UK. And again, there was a survival difference between high volume centres and low volume centres. Oops. So for us, how do we change and improve on this? Why are we seeing these differences? We should put our heads together to identify these challenges and barriers. Let's come up with concrete plans and ideas so that we don't continue to have these same stats year after year repeated where our regional patients are disadvantaged. So if volume is everything, how much volume is typical in a specialist brain cancer centre? And we've got stats from one such centre where we see at least 100 plus, sometimes even up to 150 new brain cancer cases, about 25 or 30% of the state total. These cases will go through the whole protocol of specialised care from surgery to radiology to pathology to radiation to medical oncology and to clinical trials. I want to come back to MDT because, and we touched on this earlier, this is an important element of a specialist brain cancer centre, where the membership includes specialists that do nothing but brain cancer reading, research, they publish papers, they look at everything from head to bottom about brain cancers. Often during the MDT discussions, we are switching from the latest paper published to the patient in front of us and back and forth about the psychosocial elements. These academic and research discussions are integrated with the practical challenges in symptom control, and sometimes we even like, how do we find a specialist, occupational therapist that will do driving tests for our patients? In our regional centres, this is much harder to do. MDTs do run there too, but often it is mixed in with other cancer types, like breast, prostate. The volume of other cancer types naturally dominate a lot more of those discussions, and unfortunately they can't spend as much time on them. We are most fortunate in our centre in particular to have specialist nursing care led by our nurse practitioner. Most of you know who Marina is, sitting at the back. Our nurse practitioner, I was like, oh, so what do you do each day, Marina? On average, 20 phone calls a day, 30 emails from patients. That's in addition to, I guess, me, Jonathan, Michael, Helen, Ray, emailing her, ringing her left, right, and centre, as well as other regional centres calling. A lot of calls are from carers, not just from patients, and these calls can last from 5 to 15 minutes. Last week, I think she said she took a call for 1.5 hours. A lot of the times, they're just seeking reassurance. And would be classified as psychosocial support, but sometimes it is about medication adjustments as well, with the steroids, with the seizure meds, and Marina had to go through special advanced training in nursing to do this. There's also the other elements to supporting the carers and the families with disability parking forms, Centrelink, NDIS, superannuation, the whole lot. And as I said, there's also calls coming from the regional centres as well. Taking a step back, I thought, what are some of the more general regional challenges that we are seeing? I think late presentation might be one of the issues, and it's not down to just patients being more stoic in the country. Access to primary care is challenging. So in the regional centre that I work, it's a fly-in, fly-out oncology clinic. Post-COVID, we lost about 10 to 20 GPs in 1 to 2 years, straight after COVID. That's probably covering 1,000 at least, 2,000 if not 3,000 patients in that area. And it's not just in the centre that I fly into, it was like the satellite centres at 1 hour, 1.5 hours from the main town. There's also stigma attached with brain cancer diagnosis. And given the limited resource, given the limited time that these GPs have, a lot of the times they might be thinking like, well, you've got a brain cancer diagnosis, I can't do much. And the time investment is also critical for our regional oncologists. They want to care, they want to look after everyone, but unfortunately, for them, when they go to an educational event or if they attend a national or international conference, if they have to choose between breast cancer and brain cancer, they probably will steer towards breast cancer to update and keep themselves current because they've got truckloads of breast cancer patients coming through each day. Whereas for brain cancer patients, they might get 1 or 2 a month. So they need to invest their energy wisely. Distance and traveling is a big issue, and I'll come back to this in my next slide. And I guess I dare say the lack of psychosocial and adjunctive support services is a big problem and a big challenge for us in the country as well. And of course, driving. We encounter this problem in Sydney quite often. Everyone wants to ask, when can we drive? And like, not being able to drive in Sydney is hard enough, but let alone when you're living out in the bush. So in terms of my personal experience, so as I said, I did a fly-in, fly-out clinic for 10 plus years. In Sydney, my consult time can be 20 to 30 minutes each slot. In the regional clinic, 10 to 15 minutes if we're lucky, because a lot of the times it's double booked. And if you're delivering a couple of bad news, you'll be 1 hour, 1.5 hours behind very easily. Imaging, readily available in Sydney with PETs, MRIs, whatever we need. Imaging can be quite a difficult challenge in the country. Machines break down, and then it takes ages for the parts to be found and to be fixed, and sometimes the machine's working, but the technician is not there to run the machine. In Sydney, we've got specialist nursing support that's dedicated to brain cancer or lung cancer or whatever cancer. Up in the country, it's one senior nurse covering the whole lot, coordinating everything. I've talked about, I'll touch on distance and travel. So access to clinical trials, if we don't have something in our centre, you cross 2 suburbs and you can probably get to a hospital with something comparable. Again, that's a bigger problem when you're living out in the regional centres. Getting onto a trial is not just saying, I'm going to sign my name on this consent form. There's a lot of work before you put your signature on the form, and there's a lot of activities after you sign your name on the form. And so that 2-3 months period is quite critical, and quite often you really need to be almost living right next to the hospital for it to work, which obviously if you're living 4 or 5 hours away from Sydney, that's not easy to do. Another thing I've noticed, I guess, is palliative care and hospice availability. That's hard as it is in Sydney, but that's even harder in the regional centres. To the point where in the area that I used to work, there was no specialist palliative care physicians and there was no hospice. And not to mention, of course, adjunctive services, in particular rehabilitation is such an important thing for our brain cancer patients. But again, the lack of resources is driving some of the stigma that's perhaps is translating into difficulties that we have in trying to get our patients into rehab facilities, because again, a lot of these doctors or nurses are going like, to put it bluntly, why bother? So in summary, for brain cancers, I hope that everyone has got a sense of that there's 2 very broad categories. Lower grade tumours diagnosed in the younger population and higher grade tumours diagnosed in the later life. And their care needs are very different. One group is considering how best to navigate this chronic diagnosis whilst getting on with life. Another is faced with a sudden devastating situation that will impact on their longevity. We need to increase our support for nurses, psychology, adjunctive care, for our carers, for the patients. And interestingly, like we've highlighted, there is a difference in the case mix, in the case load rather, and survival data between metro and regional patients, but we don't know why. But we need to work on how we're going to extend our specialist brain cancer care to the regional centres. So with that, for the next part, I'm going to stop speaking, hooray. We will hear from our patients, carers and colleagues from the regional centres and hear from them their perspectives in their own voice, their experience in managing and living with brain cancers in the regional centres. After the video, we'll hear from Professor Michael Back, who will give his thoughts and views on how best to tackle these challenges. And then finally, we'll have Dr. Jonathan Parkinson, neurosurgeon, give the closing remarks. Thank you.
I'm Associate Professor Rob Selensky. I'm a medical oncologist practicing here in Orange, New South Wales on Wiradjuri lands. I'm a multi-tumour stream medical oncologist, so I treat brain cancers, but I also treat 5 or 6 other types of cancers. So in the Western New South Wales Health District, we've never had a truly focused subspecialty care model for brain cancer patients. And that's clearly something that's necessary to improve outcomes. Currently, we have medical oncologists like myself who treat brain cancer patients, but also treat melanoma, lung, prostate. And given the complexity of all of these tumours and the advances in the scientific discoveries, it's very challenging for us to stay at the absolute pinnacle of our knowledge for all of these tumours. We are blessed, though, with radiation oncology services that visit us from Sydney, and we have subspecialist radiation oncologists who treat gliomas. Prior to this development, we had general radiation oncologists treating all cancers, and I've certainly noticed a very big shift in delivery of radiotherapy and in total care of the patient with this model. All of the surgery that's necessary for brain tumours is performed in Sydney. It's not performed out here in the region, and rightly so. So there's a lot of travel involved in the initial diagnosis of a brain cancer for our patients. We've also only had general care coordinators to look after brain cancer patients along with all the other types of cancer patients. And so that's our care coordination service at the moment.
In Western New South Wales Local Health District, we have 2 radiation oncology departments, so one in Orange and one here in Dubbo, and we have 3 linear accelerators over those sites. So we're able to treat most brain cancers that are eligible and suitable for radiotherapy. We do a program called SRS, so that's stereotactic radiation therapy or radiation surgery, and that's a very advanced world-class approach to treatment, and small lesions can be treated with radiation. So it's really amazing to be able to do that in a regional rural area, and a great opportunity for patients to not have to travel away and have that level of care. Professor Michael Back is the radiation oncologist that oversees that delivery of care, and it works to such a world-class level because he's able to do that as a VMO, and often he doesn't need to be here. We have the technology that Professor Back can be in Sydney, and he can video health into those patients and meet them and do consultations. He's able to do the radiotherapy planning and voluming and telling us as radiation therapists what he wants from Sydney. So that model and the technology is amazing to be able to deliver that world-class care.
I think, however, there are some issues with access to allied health services, and where we really fall short, even though we're able to provide world-class standard of care from a medical perspective, we're not really able to provide adequately resourced brain psychology, brain occupational therapy and brain physiotherapy, because there's difficulties in attracting people and difficulties retaining them once we do.
I think the biggest challenge has been for me personally being able to be across all of the nuanced developments in the systemic therapy of gliomas. Given that I'm a multi-stream medical oncologist, which is common across all the regions of Australia, it is incredibly challenging to stay abreast of what exactly is happening in every single tumour stream and where we should be looking or pushing the patient. Guidelines are very, very successful, and they help coordinate standardised care, but what patients want are clinicians that are looking for niche opportunities, areas where they could be treated a little bit differently. Clinical trials is a big example of that area that I'm talking about. We've never had a clinical trial for brain cancer patients in our district. However, we've had innumerable trials for other cancers. So there's a big challenge and a big discrepancy in getting access to clinical trials. And I regularly get asked by my brain cancer patients, are there any trials? And indeed they are, and they're all in Sydney. And so again, there's a huge travel dislocation both to them and their carers, because more than a lot of the tumour streams that I treat, they really do rely on carers, because there's often a lot of cognitive impact, mobility, vision, which we don't see in other cancers as much. So a big challenge is access to clinical trials. A big challenge is being able to sort of rightly say that you are a neuro-oncologist, and most of the world leading places would have neuro-oncology as a discipline. And I think the lack of a navigation care coordinator dedicated to brain tumour patients is clearly a huge challenge. Again, we've got care coordinators who look after lots of different types of cancer patients who all have slightly common but also unique needs as well.
The biggest challenge we have is workforce. So attracting and retaining staff in regional areas is very difficult. The state government are very good as far as offering incentives and things for people to come and work in regional areas. And at the moment we do have good radiation therapy capacity with staffing, but we do care coordination, nursing, allied health, all the extra services that are required to give it the best patient-centred care and holistic care are fairly lean in the regional model.
So, as with all rural and regional sites, there's a gradient in terms of how rural you live and how much toxicity you have. And it's not just usual toxicity that we think of with chemotherapy, but it's time toxicity, it's financial toxicity. And I don't think that's discussed enough. Really, if we're trying to do best standard of care, would be able to provide people with navigation to services and adequately provide those services closer to home so that people are able to access them. And another gap that we certainly see in rural areas is access to clinical trials. Large pharmaceutical companies don't like investing in clinical trials in rural areas because we don't recruit as well, because the centres are smaller. If we're going to be able to provide world standard care in rural areas, there need to be incentives for large pharmaceutical companies to provide clinical trials in rural sites.
Yeah, I mean, so there'd be great services that we could provide. Things like having sort of a dedicated neuro-oncological nurse. That would go great with helping manage their care. As I said previously, it's quite an advanced sort of care in terms of their surgery, and everything's quite protracted and sort of across different regions. So managing that care is one of the harder parts to go with. And I think it's quite essential care with cancer care services. Yeah.
Navigation, I think, is probably one of the big benefits that we could address, ensuring that things are sorted for patients to be able to get to Sydney, accommodation for them to stay, and then transfer of care, making sure that we get effective communication from those centres, and then that they're getting on treatment in a timely manner as well. That referrals are coming through appropriately. There's no gaps or misses in those systems. And in large, we are doing that at the moment. But I think could always be improvements in the way that happens.
My name is Scott Brown. I'm 53 years of age and I have stage 4 brain cancer. To be honest, the hardest part was coming home, was leaving the hospital in Sydney, and was to come home and having that from leaving hospital to the time to first talk to our professor is where I found it the most difficult. It was the most depressing, saddest part that I found. It wasn't until I was able to physically talk to someone and to meet the team that was going to look after me and help me that things started to improve, that I started to feel better about myself. Would be probably the biggest thing would to be have that person that you could talk to within a couple of days after having your treatment and everything like that. I was lucky in having, when I did my all my radiation treatment, I had 30 shots of radiation, and to have a nurse that regularly contacted me once I'd finished that, every 3 days was nice. They would sit down for those 10, 15 minutes or whatever and talk to about it and things like that. And that lasted for a couple of weeks, and then that was the next stage. They said, we have to give this up now and move on to another stage. And after that period, you had really no one to talk to. Like, you had your family, but it's not like having someone that that's class is independent, if you want to call it that way. Someone that you can sit down and have a really good nice chat and discuss, little problems that you're facing, you seem to be facing. You don't want to keep taking this back to your family all the time and feeling bad about. So,
yes, I'm Gavin Smith. I'm a resident in the Bathurst area, and I'm 68 years of age. And I was recently diagnosed with a tumour. Well, there was really nobody I could turn to for like face-to-face information straight away. I actually received a lot of information when my daughters researched things online, and I really missed not having someone to talk to when I was first diagnosed, because I just didn't know, what to expect or what was going to happen. And that was a difficult time. I did notice when I had surgery in Sydney, there was a lot of people were in supporting roles down there, and I noticed that there's probably just not the numbers here to support people in the regional areas. I just noticed that straight away. Yes, we have to travel, for treatment we have to travel 150 kilometres every day. So it puts a little bit of extra strain on the family, the other family members, because they've got to make allowances for us leaving early and all the rest of it.
Hi, my name is Sharon Brown. My husband Scott Brown was diagnosed with a glioblastoma in March 2024. We've been married for 31 years. He was diagnosed the day after our 30th wedding anniversary. From then he was flown to Sydney, and that week he was operated on, had a part of his brain removed. Obviously the initial diagnosis is very traumatic to hear that your husband of 30 years, has terminal brain cancer. It's news that no one wants to hear. Obviously we have 2 adult daughters. They were there when we got the diagnosis, so as a family I'm just glad we were all there together. But coming home, obviously it's a lot to wrap your head around, to try and make a plan of how to move forward. It was a bit of a struggle because you're trying to, obviously get your head around it emotionally, but then also too at the same time, you still have to live a life somehow, deal with work, deal with your family. We're pretty lucky with the Western Cancer Centre. If we didn't have this here in Dubbo, it would definitely be a lot more difficult having to go to Orange or possibly Sydney for Scott to have treatment. So we are lucky in that respect. However, I feel like we need more services here, especially when it comes to like that higher end doctor, like a neurologist. We were having to travel to Orange when Scott first started having symptoms a few years ago. So that's a 2-hour drive for us. Obviously that impacts your work when you're trying to work. Scott would often be working remotely, so to make that plan, it wasn't just a simple thing like you could just take a few hours out of your day. It was a full day thing. Also, once Scott started treatment, his radiation oncologist flies in from Sydney.
Hi, I'm Esther Beshman, and I am a carer to my husband Scott, who has glioblastoma, which is stage 4 brain cancer. I'm a mum to 2 little people as well, so 2 and 5, so trying to manage the needs of little people, plus also being a carer for my husband, I found really, really hard trying to make sure everyone's needs are met. And I'd also say in terms of the psychological impacts and the changes that I've noticed, the depression, the desperation, that emotional toll that has on someone of a younger age, I think isn't spoken about enough, in terms of when you've got a 35-year-old male facing his mortality instead of thinking about the beautiful little kids that he's going to see grow up. No one can prepare you for that, and I think being the carer for that person, you're their emotional ambassador, and you've got to try and carry them, but you're also trying to carry your own weight and your own pain through that. So I think psychological support could go a long way in helping people with brain cancer in particular. We now have accessed a neurologist in Sydney, and we do telehealth appointments. But I really miss that genuine face-to-face connection that you can build with your medical team. You've really got to trust these people, and it'd be really lovely if you could actually sit down face-to-face. But due to where we live, you're dealing with the isolation and then trying to communicate through a video, like a TV, a laptop screen. It's really challenging. Same with Michael Back, our radiologist. Beautiful man, have had many conversations through telehealth and through email, but I've never met him in person. But yet he's been a vital part of my husband's care, but I haven't had the privilege of meeting him. And so I think building relationships is what people really value in this process, because it takes such an emotional toll on you.
I think it's many things, but a lot of it is awareness. I think we have a good model where we have expertise from metropolitan sites working as subspecialists, supporting our delivery of care and our decision making. And then we have a local team who are able to deliver that world-class care. And I think that really does bridge the gap between metropolitan and rural. However, it's that ongoing workforce that we really need to keep a focus on, to make sure that we have the support roles, the allied health roles, the care coordination roles, and they're often a bit leaner in a regional model because we don't have the high number of patients to actually be able to demonstrate the need for all of those roles.
Bridging the gap, to me, looks like providing adequate allied health resourcing in addition to the medical resourcing that we've seen locally. That's not just in physiotherapy, psychology, occupational therapy, but also things like nurse navigators, cancer navigators within communities, Indigenous navigators within local communities, to help to bridge that gap and to make it seem less alien that people have to travel to the big smoke here in Dubbo from the community that they live, which may be hundreds of kilometres away. Bridging the gap doesn't just mean providing world-class medical care, it means providing care across the spectrum in all allied health, psychology and nursing domains.
I think the space inside a carer's head gets really overwhelmed and overstimulated, and I really feel like if you could have a central person, like a key contact that you could go to that has a checklist that could help you work through all the things that you need to navigate in terms of organisations like Can Assist that can help, the Cancer Council, doing the NDIS application, all of those things to help navigate and to keep you somewhat accountable, to say, oh, like, how did you go making that appointment and following up on that? Because I do think there's some wonderful services, but unless you don't know to call, or you get really busy in the running to the chemist to fill the script or going to all the medical appointments, that all those other things that really matter, I think you just forget to do. And so having a key contact, someone you could refer to help with that process, I think would be really helpful. I do find that there's a big gap between New South Wales Health and NDIS. NDIS seem to not want to assist with end-of-life preparation. They say that that's a responsibility of New South Wales Health. However, in our experience, and for my husband who has probably less than 6 months to live, New South Wales Health asks the question, are they an NDIS participant? And if you answer yes, then that's where the draw is. That's when the line's drawn, and then they say refer to NDIS, and then you refer to NDIS and they refer you back to New South Wales Health. At the end of the day, Families just want to be as prepared as they can be about preparing for death and what that looks like. And I think, it should just be about the support rather than the person delivering it.
I probably would ask for a bit of equality between the metropolitan and regional areas. There's just not the support in the regional areas compared to the metropolitan areas. From what I saw, of my experience with the hospital in Sydney.
Please, when you make these decisions in Parliament, think of people in the bush. We count too. And there's a lot of us out here. You don't realise how many people rely on the services in Dubbo. It's not just us in Dubbo or the closest towns, like people in Burke and Broken Hill and all those places, they rely on Dubbo. So the more full-time services we can have here definitely gives people more options.
So if you're listening to this and you have the ability to help rural patients with brain cancer, my plea to you would be, we need to set up almost network centres of care where all rural regional brain cancer patients are connected to a neuro-oncology dedicated service. I don't think these patients should be left out in the country with services that are just not appropriate for this day and age. And by that I mean, having access to all the latest research, evidence and technologies to help manage their tumours. So please help us and let's work together to increase research. There clearly needs to be far more clinical trials in brain tumours, and let's work together to bridge the gaps that we've identified. Thank you.
Well, thank you for the opportunity to follow up on that video there. There's a lot of emotion in a cancer centre. There's a lot of community in cancer centres. We see a lot in cancer centres in Western New South Wales, an example there. But there's 59 regional LGAs across New South Wales. So there's a large number of areas that require help. So my name is Associate Professor Michael Back. I'm a radiation oncologist. I'm based at Royal North Shore, but I'm also a VMO in 3 regional cancer centres, one Gosford, which is still defined as a regional cancer centre, and also at Dubbo and Orange as part of Western New South Wales. This little pamphlet which you have is really the summary of what I'm going to pitch. And I think we've heard from there the issues that are related with brain cancer. Now, obviously, the major issue is we're not winning. We're not doing well enough at the moment. We need to get above that 28% 5-year survival. And there's a lot of initiatives which are coming through from overseas and also from here, which we try to drive. And that is the major thing. And I reflect on people in the audience who have lost their loved ones along this journey. And obviously, that is our primary goal, is to try to improve that cure and then alongside improve the care of our patients going through that whole illness pathway and the families as well. Tonight we're sort of pitching a little bit differently, where we're trying to reflect on that gap between metropolitan and regional centres, and it's there. It's a really hard task. I worked in Singapore for 6 years. It was 42 kilometres wide, and people complained about access to services. They built an MRT station, a train station, in the hospital, to make sure the patients could get there. Because people were complaining that, it's too difficult to get to the hospital. Australia is completely different. We see that we get a referral from Western New South Wales, and the first thing we do is to go to Google Maps and work out, where is this town? I've got no idea where this town is. And you find out it's 180 kilometres away from Dubbo. And you say, okay, let's just call the patient, do the Zoom meeting from home. We don't need to bring the patient in for that first discussion consultation. And I guess you've got to work around some solutions. And most, in fact, all regional centres around New South Wales have worked those solutions and try to work out the best approach. One of the wonderful things that came through from, it's probably 2007, Kevin Rudd's era, the federal government built and funded a whole lot of regional cancer centres. It was great. And funding went out to put radiotherapy services in regional areas, which reduced the tyranny of distance for travelling for cancer care. Unfortunately, over the time since then, we've learnt a lot about outcomes in cancer medicine. And one of the major outcomes in cancer medicine is provider volume. Some of the slides that Adrian showed. It's come through from the surgical experience, but it's now also seen in overall cancer care, radiation oncology care, and other care factors, where the more people you see, the more times you do something, the better you probably get at it. And the data suggests there's better outcomes when you've been seen in a centre which has got a larger provider volume. You can't do that in Western New South Wales. You can't do that in Southern New South Wales because the numbers aren't there enough to sort of build that up for one clinician working out there. So as a result, that clinician working out there would manage the breast cancer, the bowel cancer, a bit of lung cancer. They would subspecialise maybe in that, and then they would do a little bit of the brain cancer on the side. And that's very difficult to keep abreast of all the changes which are happening, the subtleties which are happening in the neuro-oncology sphere. Some of those patients' tumours have changed their name 3 times since 2008. The classification's changed. Everything is sort of altering. And we're learning more about different aspects of patient care. So we need that sort of provider volume for people to come up to speed with things. I managed a lot of breast cancer in my time, and from 96 as a specialist through to 2011, I thought I was, I knew all about breast cancer and I managed breast cancer regularly. I can't treat breast cancer now. I'm out of the zone. I don't do that anymore. I just do brain tumours. I can't go back to treating breast and prostate cancer because I wouldn't know what to do. Even though I attend a meeting once a week to get updated on what each of the teams are doing, I don't have that subspecialty expertise. So how do we get that around that in the regional centres? Well, neurosurgery, we can't provide these services in each LGA or each area health service. So the New South Wales government's got linkages. So patients in Western New South Wales flow straight through to RPA. Patients in Gosford flow straight through to Royal North Shore for their surgery. But what happens is that patients go back to the generalised regional cancer centres and there's no subspecialised care subsequently to that. So they miss out on it. We've got great clinicians such as Robert Zielinski and Florian Honeyball and multiple other medical oncologists and other radiation oncologists around town in those regional areas who are doing a great job. But it's hard for them to be having that pure subspecialised model. So we've got to try and work that. So part of what we're pitching to New South Wales Health is to get around that by providing that provider volume, by demonstrating linkages for low incidence cancers like brain cancers to be managed in relationships between major centres. The word mentorship doesn't apply. You can mentor someone, but you've got to need to be able to be doing it. You've got to be able to follow those patients. You've got to be able to have your hands on with those patients. So it's not just keeping an eye, you actually have to be delivering or assisting with the delivery, designing the treatment for those patients, not just providing a mentorship. So there needs to be a formal relationship, and it can be done under health schemes. We've been able to do it through Western New South Wales, and it works successfully through a major centre, metropolitan centre, providing that assistance out there. Now, we have services on the ground as well, so team members who are more generalists will look after patients during the course of a treatment, but the design, push comes to shove, analysis, review of imaging, etc., comes back to the subspecialised clinician. But we need to try and push for those relationships. And it is able to be done, it is feasible, it just has to be acceptable that one local health district will be able to have a formal relationship with another local health district. We do it with surgery, we can now do it with more generalist types of cancer conditions. So we want to push for that and try to encourage the government to start looking at that and reflecting that the regional cancer centre has been a great model. It's actually providing the care in the areas, but we can utilise the improvement in digital technology and communication to actually get some of those services more specific, more subspecialised on site. The second aspect that came through tonight was the supportive care, and speaking with people in the foyer as well, it came through. There is a vast deficiency in supportive care in metropolitan areas, but also within regional areas. Now, there's lots of great initiatives which have been set up around by not-for-profit organisations, by federal government programs, which are out there and probably underutilised, linkages with NDIS, etc. And there's no one there to really coordinate it. We can't put a care coordinator into every regional cancer centre specific for neuro-oncology. There's not enough work for that to be done. It'd be inefficient use of resources. So for instance, in Western New South Wales, I might see 2 new patients a month. So there's not enough work for one person to be undertaking as a specific neuro-oncology care coordinator. As a result, as Rob Zielinski mentioned, that supportive care gets shared. The person who's looking after the patients with brain tumours may look after patients with breast cancer or colorectal cancer. And so that ability to actually provide specialist care, specialist advice, as some of the carers are outlining there, is not available for brain cancer. One of the initiatives we do have, however, is potentially to place one care coordinator or one nurse practitioner as a navigator in one centre, but have that person linked to provide the support in a virtual way for multiple other centres around New South Wales. The federal government has rolled out the funding for care coordinators to the McGrath Foundation. They're trying to copy the model for breast cancer that's been done by the McGrath Foundation quite successfully. However, each different cancer site has its differences, and the model they're rolling out is generalist nurse practitioners or nurse coordinators who will be looking after multiple subsites. And therefore our patients with specific needs for brain tumours will slip through the cracks. They won't be seen. But we could potentially have a centralised nurse navigator in one area of New South Wales, linking in with multiple different LGAs, getting the practical experience and practical implementation on the ground, but then being a coordinator for multiple different areas around. And that way we can potentially get access to federal government programs, state government programs. There'll be a community of navigated care coordinators who will be able to communicate with each other and try to provide an optimal care for our patients with specific needs in neuro-oncology. That is an achievable model. It's one FTE for probably 4 or 5 different regions. So 5 staff members, and it can cover we saw the numbers, 44% of patients are being diagnosed in regional LGAs. It's not a city or an urban illness alone, but all of our resources are based in metropolitan areas. Our specific resources are there. And that's an opportunity we should be able to explore and should be able to take. The final thing was access to clinical trials, so crucial for our patients to have cutting edge exposure. There is a difficulty in running sort of very standardised clinical trials. But one of my patients from Western New South Wales, he lives about 150 kilometres from Orange. We enrolled him on a trial at a metropolitan site. He would drive 150 kilometres through Orange and then the rest of the distance through to Sydney to have an MRI that no one else saw him on that day, have the MRI and then drive all the way home. He could have had the MRI in Orange, but no, the clinical trial agreement said it had to be with the MRI unit next door to the Metropolitan Hospital. So as a result, the patient and his wife would drive in a total of 600 odd kilometres just to get an MRI, which no one looked at on that day. That MRI was able to be seen by me on the train home between Chatswood and Gordon. Not at Gordon because the line drops out. But between Chatswood and Gordon, I was able to pull that up on my laptop, call the patient and explain what the results of the scan was. So it can be done so easily. The clinical trial rules have to be adjusted in Australia to account for the differences. And we have to lobby the clinical trials, or at least provide an additional subsidy for patients with clinical trials or to companies to provide those clinical trials in regional areas. It can be done. We just need to lobby it and we need to flex the rules a little bit. It's important for those clinical trials to be run. Rob Zielinski's got a great clinical trials unit in Orange. He runs trials. Florian runs trials in Dubbo. the infrastructure is being set up by New South Wales Health to do that, but we need the ability for some flexibility from the people who sponsor trials, from the ethics groups, to allow some flexibility for country patients to have their reviews distantly or to have their investigations done locally. So these are not huge, expansive things. We're not trying to set up a new cancer centre and try to staff it with multiple people. We're trying to use the initiatives which came through COVID, which were really good in communication. We try to use the initiatives which are out there in government areas for communication around. And we can do that, and our patients are willing to do that. If it's an established partnership, we can have services on site which are linking in with the specialised services in a metropolitan area. And that also improves the education of people on site in that region. So they're the sort of things that we're looking at, not huge funding requests, but we're trying to lobby for those aspects to come through so that we can bridge that gap that does exist, and the statistics tell us, between what happens in regional areas and what may happen in a metropolitan area closer to Macquarie Street. And thank you very much for listening to us tonight on that.
Well, thank you, Michael, and it falls to me to draw this evening to a close. Jonathan Parkinson's my name. I'm a neurosurgeon and director of the Brain Cancer Group. Just to recap what we've heard tonight, firstly from Adrian, we've heard about brain cancer and just how complex a disease it is, and how complex the treatment therefore is, and why at the Brain Cancer Group we have our 3 pillars of research, education and support, and how we feel each of these is important in forwarding the care for brain cancer. Adrian also highlighted a lot of the regional differences, as we've talked about. But I don't know about you, but what sort of came through for me was the area of support, that pillar of support, and how we can do that better to help our brain cancer patients. I'd like to particularly thank Dennis Trataris from Arama Communications for putting that video together. I thought that was very moving and very compelling. Dennis is the guy walking around with the camera now, still taking photos, and at the Brain Cancer Group we couldn't be more grateful for what Dennis does for us. And I thought it was particularly brave of the patients and carers who appeared in that video. I found that particularly moving, and certainly seeing some of the faces around the rooms and knowing some of your journeys with brain cancer, your support is invaluable. So thank you again. Fortunately, Michael offered us some solutions there, and some of the ways that we feel like we could move things forward with bridging this gap between care between the metropolitan and regional centres. I think there are a couple of really good points there around provider volume, but also around access to clinical trials, and it's something we know that patients who are involved in a clinical trial will tend to have better outcomes than those that are not. And again, this sort of speaks to the Brain Cancer Group's pillars of research, but also support and the models for providing care navigators and care coordinators for that. Finally, I'd like to just thank everyone who made this evening possible, particularly Sophie Kotzes for hosting us here again, the politicians from regional areas who've attended. We'd like to thank you, particularly the member for Bega who was here, who had to go, but he's also the Parliamentary Secretary for both health and regional health, so to say that his interest was piqued is probably an understatement. And lastly, I'd just like to thank everyone from the Brain Cancer Group who helped put this on, both from an administrative perspective and all the clinicians, and of course finally everybody who attended tonight. Thank you for the support you offer us, and we look forward to this continuing relationship. Thank you.